Let me start with a simple question. Do you know someone who has been diagnosed with a genetic condition, or someone who has lived with unexplained symptoms, delayed diagnosis, or health challenges that never seem to fit neatly into one box? In this masterclass, you will discover how rare genetic conditions such as Turner syndrome offer powerful insights into how the human body adapts, survives, and builds resilience, even when key biological elements are missing. Today's session is not about labeling people as broken or deficient. Instead, we'll explore how biology expresses strategy, not failure, and how early signs, often overlooked, can completely change outcomes when they are understood correctly. You'll learn how rare genetic patterns reveal deeper truths about human health, why diagnosis is often delayed and how that delay impacts quality of life, how medical strategy, early intervention, and support systems transform long-term outcomes, and how strength can exist quietly, long before it is recognized, whether you are a health professional, educator, caregiver, parent, patient, or simply someone seeking a deeper understanding of the human body. This masterclass is designed to expand your perspective, because small does not mean weak, and difference does not mean deficiency. It often means untapped insight. Welcome to Small But Mighty. Let's begin.
We're starting today's deep dive with just 4 words.
Oh, I'm intrigued.
Usually, we kick things off with a big statistic or some breaking news headline. But today, it's just a phrase I found. It was kind of buried in the clinical notes for this topic, and I just couldn't shake it.
Okay, what is it?
She's small but mighty.
Ah. Yeah, it sounds almost like a bumper sticker, doesn't it? Or maybe a superhero tagline.
Exactly, a superhero tagline. But in this context, it's a profound summary of a very specific and very real genetic reality.
It really is.
And that is exactly what we are here to unpack today. We're looking at a whole stack of research that centers on Turner syndrome.
Right.
That's where this small but mighty descriptor comes from. But the scope of our deep dive today is actually, it's much wider than just one condition.
It has to be.
We're using Turner syndrome as a kind of lens, a case study really, to understand this broader, often hidden world of rare genetic disorders.
And that shift in scope is so vital. I'm glad you're framing it that way, because while Turner syndrome has its own very unique biological fingerprint, the journey of the patient, from, the initial confusion of the symptoms to the long battle for a diagnosis, and then the lifelong strategy of management.
That part of the story.
That is a universal story for the entire rare disease community. It's a shared path.
So if you're listening right now and thinking, okay, but I don't have Turner syndrome, why does this matter to me? Well, it matters because this is basically a masterclass in human resilience.
Absolutely.
It's about how biology might dictate the small, but the human spirit, and of course medical intervention, that's what defines the mighty.
A perfect way to put it.
So let's start there. Let's start with the biology. When the source material says she's small but mighty, let's just be literal for a moment. What exactly is making her small?
Biologically, we're talking about the X chromosome. And just to get back to high school biology for a second.
Please. A refresher is always good.
Typically, a female has 2 X chromosomes. We write it as 46XX. That's the standard blueprint.
Right.
In Turner syndrome, one of those X chromosomes is either completely missing, which we call monosomy X, or it's structurally altered in some way.
Altered how?
It could be a partial dilution, like a piece is missing, or it could be a ring chromosome, or in some cases, it's only missing in some cells, which is a condition we call mosaicism.
So the genetic blueprint itself is physically smaller. There's less data available to the body.
Precisely. You've hit it right on the head. And the small in that phrase, it refers most directly to physical stature.
To height.
To height. There's a very specific gene on the X chromosome called the SHOX gene. SHOX.
What does that stand for?
It stands for short stature homeobox. You can think of it as the architect for your long bones. It tells your arms and your legs how much to grow.
And since girls with Turner syndrome are missing that second X chromosome,
they're missing the second copy of that crucial gene. The technical term is haploinsufficient. They only have half the dosage, you could say, of those bone growth instructions.
Half the dosage. Wow.
So without any medical intervention, a woman with Turner syndrome might only reach an adult height of about, say, 4 feet 8 inches. That is the small.
Okay, that makes sense. It's a direct biological consequence. But the phrase isn't just she's small.
No.
It's small but mighty. And I feel like that word mighty is doing a lot of heavy lifting here. Is that just us trying to put a positive spin on what sounds like a really hard diagnosis?
Not at all. I mean, I understand the skepticism, but there is a genuine biological toughness here that is, it's astonishing, really.
Tell me about that.
You have to understand that for the vast, vast majority of conceptions where an X chromosome is missing, the pregnancy doesn't survive.
Oh.
It's estimated that something like 99% of fetuses with monosomy X are naturally miscarried, usually very early on.
99%.
It's a chromosomal arrangement that is, in most instances, simply incompatible with life.
Wow. So just being born with Turner syndrome means you've already beaten a 99-to-1 odd.
Exactly. Every single girl and woman walking around with Turner syndrome today is a biological survivor of the absolute highest order.
That's incredible.
They have overcome a massive genetic deficit just to take their very first breath. That is mighty.
That completely reframes the entire conversation.
It should. It frames the condition not as a tragedy of what's missing, but as a triumph of what's present and what has endured.
So it's not about being broken or incomplete. It's about being incredibly durable from the start.
Incredibly durable. But, of course, durability doesn't mean it's an easy path.
No. And that's where our source material transitions us pretty quickly. It moves from this overview right into diagnostics. And I love the phrase it uses. It calls this process the detective work.
A very fitting term. In the rare disease world, we often call this the diagnostic odyssey. It can be a long, confusing journey.
An odyssey.
And for Turner syndrome, the detective work can happen at 3 completely different stages of life. And the clues the doctors are looking for are totally different at each stage.
Okay, let's walk through those stages, because it really seems like when you find out has a huge impact on what your journey looks like.
Absolutely. The timing is everything. So the first stage is prenatal, before the baby is even born.
How does that happen?
This is becoming much more common now with NIPT. That's non-invasive prenatal testing.
The blood test.
Right. They draw blood from the mother, usually around 10 weeks of pregnancy, and they analyze the small fragments of fetal DNA that are circulating in her bloodstream.
And they can see the chromosomes from that.
They can screen for certain chromosomal abnormalities. So if they see a discrepancy in the sex chromosomes, if they're expecting to see XX but something looks off, it flags a high risk for Turner syndrome.
That seems like the quote-unquote best case scenario, doesn't it? You know, before the baby arrives, you can prepare.
In terms of preparation, yes, it gives you time to learn, to find specialists, but it's also incredibly complex emotionally.
How so?
Well, for one, NIPT is a screening tool, not a definitive diagnostic one. It can be wrong. You can get false positives.
Oh, right.
Or it might pick up a high risk for Turner syndrome, but then you go for an ultrasound and the baby looks perfectly fine. No physical markers at all.
So you're left in this limbo.
A terrible limbo. The parents are left wrestling with this idea of, is she small but mighty, or is she just typical and the test was wrong? And they might not get a clear answer until the baby is born and they can do a direct blood test.
That sounds agonizing. Okay, so what's the next stage? Diagnosis at birth?
Right, in the nursery.
What are the detectives looking for there? What are the immediate clues?
The biggest one is lymphedema.
Lymphedema.
It's a specific kind of swelling. In utero, the lymphatic system, which is basically the body's drainage system, doesn't quite form perfectly because of that missing genetic information.
So fluid builds up.
Exactly. So you see a newborn with these characteristically puffy hands and pucky feet. Sometimes there's also some extra skin around the back of the neck, which is often called webbing.
And that's a clear physical marker that says, hey, let's check the chromosomes.
It should be. A sharp pediatrician or neonatologist spots that. They order a karyotype, which is a blood test that literally maps out the chromosomes. And boom, you get your answer.
That seems more straightforward.
It is. But the group that fascinates me the most, and frankly the group that often struggles the most with embracing the mighty part initially, are the ones who are diagnosed later. Much later.
The late diagnosis. I saw that in the notes. This could happen in childhood or even the teen years. How on earth do you miss a genetic disorder for 12 years?
Because the spectrum of symptoms is so incredibly wide. Remember we talked about mosaicism?
Where some cells are typical and some are missing the X.
Right. So if a girl has 46XX in, say, 80% of her cells and 45X in only 20%, her physical symptoms might be very, very subtle.
So she might not have the puffy hands at birth.
Exactly. She might just be the shortest girl in her class.
And everyone just writes it off. Oh, she's just petite. Her grandma was short.
Precisely. Or she's just a late bloomer. She'll catch up. Everyone has a story to explain in a way, but then Then age 12 comes, age 13 comes.
Puberty.
All her friends are hitting their growth spurts, they're starting to develop, they're getting their periods, and she isn't.
Because the ovaries are also affected by that missing X chromosome.
Correct. This is a critical point. In most cases of Turner syndrome, the ovaries undergo what we call premature failure. They essentially become what are called streak ovaries, just fibrous tissue that doesn't produce eggs or, crucially, estrogen.
So the biological clock for puberty simply doesn't ring on its own.
It never rings.
Yeah.
And I can't imagine the psychological toll of that. You aren't just feeling small physically. You feel stuck in childhood while your entire social world is moving on without you.
It's a different kind of isolation.
A profound one. And that's why the diagnosis at this stage, as late as it is so critical. It's the aha moment.
Finally, an explanation.
It explains the height. It explains the lack of puberty, and most importantly, it unlocks all the insights that are mentioned in our source text. You finally move from that terrible question of why is this happening to me to, okay, this have a name, this is Turner syndrome, now what do we do?
And that phrase, now what do we do, is the perfect segue to our next section, quality of life strategies.
Yes.
I really appreciate that the source text uses that specific word. Strategies. Yeah. It implies such an active management. It's not just about taking a pill. It's about planning a campaign.
It is absolutely a campaign, and you have to be ready to fight on multiple fronts simultaneously.
Okay, so what's the first front?
The first front usually is height.
This goes right back to that SHOX gene we talked about at the beginning. If the gene is missing or half missing, how do you strategize around that?
You basically use brute force. The strategy is recombinant human growth hormone.
So hormone therapy.
It's a daily injection, usually starting as young as possible, say age 4 or 5. You're essentially flooding the body with growth signals to try and maximize whatever potential those bones have left.
A daily shot for a child sounds really tough.
It is. It's a huge commitment for the family. But if you start early enough, you can add significant height. We're talking about the difference between, say, 4'8" and 5 foot, or even a 5'1".
And I know some people listening might think, is it really worth years of daily shots just for a few inches? But the source really emphasizes this point. In a world that's physically designed for people who are at least 5 feet tall,
right,
driving cars, reaching kitchen counters, sitting at standard desks, those inches are functional. They're not just cosmetic.
They are independence. That is the entire strategy, maximizing future independence.
Okay, so that's front number one. What's the second front in the campaign?
The second front is estrogen replacement therapy.
To kickstart the puberty that didn't happen naturally.
Exactly. But this isn't just about feminization or making a girl look like her peers, though, that social and psychological aspect is huge. We can't downplay that.
Of course.
But from a purely medical standpoint, it's about bone density.
Right, because I know estrogen is critical for protecting bones.
It's the primary protector. Without estrogen, a woman with Turner syndrome is at a massive, massive risk for severe osteoporosis in her 20s or 30s. Her bones can become incredibly brittle.
So the strategy here is really preventative. You're inducing puberty medically to protect the skeleton for the next 60 years of her life.
That's it. You're building the bone bank that has to last a lifetime.
There's another section here in my notes that's bolded and underlined. It says cardiovascular monitoring. This feels like it might be the most high-stakes part of the strategy.
This is the life or death part, without a doubt.
Why is that?
Somewhere between 30 and 50% of girls born with Turner syndrome also have a congenital structural heart defect.
That's a huge number.
Yeah.
Almost half.
It's a very common comorbidity. The most frequent issue is something called a bicuspid aortic valve.
Meaning 2 flaps instead of 3.
Right. The aortic valve should be like a 3-pointed star. In this case, it's more like a fish mouth with 2 flaps. This can cause the valve to narrow or leak over time.
What else do they look for?
The other big one is coarctation of the aorta. That's a narrowing of the aorta itself, the main pipe leading out of the heart.
And here's the scary part. You might not even know you have this. You could feel perfectly fine.
You might feel completely fine. You could be a kid running on the playground, playing soccer, running track, but that aorta is under constant abnormal pressure.
So what's the strategy?
The mighty strategy here is rigorous, lifelong surveillance, regular cardiology checkups, MRIs of the chest, echocardiograms. You have to know that the plumbing is secure.
Because the risk is catastrophic.
The risk of an aortic dissection, which is a tear in the wall of the aorta, is significantly higher in this population. It's a medical emergency that is often fatal.
So the strategy is, knowledge is safety. You can't just hope for the best. You have to look.
You cannot ignore it. It's the most important part of the long-term management plan. But can I pivot for a second?
Please.
I want to pivot to the cognitive strategies because this is, I think, the most misunderstood part of Turner syndrome. The small but mighty phrase applies to the brain too, but in a very specific and often counterintuitive way.
The text I'm looking at mentions something called a nonverbal learning disability, or NVLD. Can you break that down for us? Because usually when we hear learning disability, we think about challenges with reading or writing.
And that is the trap. That's the classic misunderstanding. Girls with Turner syndrome often have typical or even superior verbal intelligence.
Superior?
Oh, yes. They can be incredibly articulate, have fantastic vocabularies. They often read very early. From a teacher's perspective, they can seem like the model student.
Okay, so where's the disability part?
It's in the performance IQ. Things like visual spatial reasoning, math concepts, and executive function planning, organizing, time management can lag far behind their verbal skills.
So she could write a brilliant, insightful essay on a historical event, but she might get lost walking from her classroom to the school cafeteria.
That is a perfect classic example, precisely. Or she struggles to read a map or a graph. Or, and this is socially critical, she struggles to read nonverbal cues.
Like body language.
Body language, facial expressions, tone of voice. If you cross your arms, sigh, and roll your eyes while saying that's fine, she might not intuitively process your annoyance. She just hears the words, that's fine.
Oh, wow. That sounds like a recipe for social isolation, especially in the middle school years.
It absolutely is, and that is where the strategy comes in. The wrong approach is to just say, you need to try harder at math. That doesn't work.
So what's the right approach?
You teach explicit strategies. You don't assume she'll pick up on social rules intuitively. You break down social interactions almost like a script. When someone does X, it usually means Y.
You make it verbal.
You make it verbal. You use her strengths to compensate for her weaknesses. You teach her to talk through the steps of a math problem out loud. You have her narrate the directions on a map instead of just trying to visualize them.
That's fascinating. It's truly about leveraging the mighty parts of the brain, the verbal skills, to build a scaffold to support the small parts.
It's a brilliant reallocation of cognitive resources, and that, I think, is a perfect bridge to the broader topic of rare genetic insights.
Yes, let's go.
Yeah, because while the specific biology of Turner syndrome, the missing X, the SHOX gene, the NVLD profile is unique, this core process of identifying strengths and managing hidden deficits is absolutely universal across the entire rare disease landscape.
Okay, let's zoom out then. The source material explicitly asks us to broaden to other rare genetic conditions. We've been really deep in the weeds of Turner syndrome, which has been fantastic. But how does this story connect to the bigger picture?
Well, first, just consider the numbers. We say rare, and people think it's, well, rare.
Right, something that happens to other people.
But there are over 7,000 identified rare diseases.
7,000.
7,000 and counting. Individually, they are rare, maybe 1 in 2,000 people, maybe 1 in 50,000, but collectively, 1 in 10 Americans has a rare disease.
1 in 10. That's not rare at all. That is huge.
It's huge. That means everyone listening to this right now probably knows someone or knows someone who is dealing with this. Rare is actually quite common when you put it all together.
And that small but mighty narrative we've been exploring. You're saying that fits almost all of them.
In a way, yes. The small is the profound isolation. It's the experience of having a condition that your family doctor might literally have to Google while you are sitting in the exam room.
I can't even imagine how terrifying that must be, to feel like you know more about your own or your child's condition than the person who's supposed to be treating you.
It creates this very unique dynamic that we call the expert patient.
The expert patient.
In the world of common diseases like diabetes or high blood pressure, the doctor is the clear authority. There are established protocols. In the rare genetic world, the parent or the patient themselves often becomes the principal investigator of their own case.
They have to.
They're the ones tracking the symptoms day by day, reading the obscure research papers at 2 in the morning, connecting with other families online, and trying to connect the dots that the medical system is too fragmented to see.
So that diagnostic odyssey we talked about with Turner syndrome, That isn't just a Turner syndrome thing.
No, not at all. It is the hallmark of the rare disease experience. On average, it takes about 5 to 7 years to get an accurate diagnosis for a rare disease.
5 to 7 years.
That's 5 to 7 years of being told, you're just anxious, or it's all in your head, or let's try this medication for a disease you don't actually have.
That requires an almost superhuman amount of resilience. You have to be mighty just to keep showing up to appointments and advocating for yourself.
You have to be mighty just to trust your own gut when the experts are shrugging their shoulders. And this connects back to this idea of insights. The source text mentions rare genetic insights.
Yes.
We often think of this as what the patient learns about their condition, but I think it's just as much about what the world learns from the patient.
Oh, that's a really interesting angle. You mean these rare conditions actually teach us about general human biology?
Constantly, they're like little windows into how the body is supposed to work. We barely understood the mechanics of human height until we studied the SHOX gene in the Turner syndrome population.
So by studying the exception, we learn the rule.
We learned the rule. We didn't understand critical aspects of the human immune system until we studied patients with rare primary immune deficiencies. These small patient populations provide mighty insights that lead to blockbuster drugs and treatments for the general population all the time.
So in a way, they're the pioneers. They're out there on the absolute frontier of genetic medicine.
They are, and they are often paying a very high personal price for the knowledge that benefits all of us. Which brings us, I think, to the final, and you could argue most important, section of our source material.
Available support groups.
The power of community.
Right. I feel like in other contexts, for more common conditions, support groups are often seen as a nice to have, a place to vent, share tips, have some coffee.
A supplemental resource.
Yes, supplemental. But in the context of rare genetics, the source treats them as absolutely essential infrastructure.
They are mission critical. I can't state that strongly enough. Because when you're dealing with something incredibly rare, a formal standard of care might not even exist yet.
So the doctors are learning as they go.
Everyone is. And in that environment, support groups become crowdsourced research labs.
Okay, give me an example of what that looks like in practice. How does a Facebook group for a rare disease become a research lab?
Okay, imagine you have a child with a genetic condition that affects only, say, 500 people in the entire country.
Vanishingly rare.
A specialist at a major academic hospital might see one new case every 10 years. They have no ability to recognize patterns. But in a private online group, you might have 300 of those parents in one place.
The collective experience.
The collective experience. And one parent posts, hey, this is weird, but does anyone else's kid have a terrible time digesting strawberries?
And suddenly 50 other parents comment, yes, we thought it was just us.
Boom.
Yeah.
In that moment, you have just identified a potential clinical symptom that isn't in any medical textbook. You have generated real-world data. This happens constantly.
Wow.
Support groups for rare diseases are often the ones driving the research agenda. They identify the symptoms that matter most to patients, they fund the initial studies, and they develop the clinical guidelines that doctors eventually end up using.
So that strategy part of quality of life,
Yeah.
a lot of that practical day-to-day strategy comes from the other parents, not from the clinic.
100%. A doctor can prescribe the growth hormone and tell you the dosage, but the support group is who tells you how to distract your 5-year-old so they don't scream and cry during the nightly injection.
The practical wisdom of the trenches.
It is. A doctor can give you the diagnosis of NVLD, but the support group is who tells you which specific clause you need to put into the IEP, the Individualized Education Program. So the school is legally required to provide the right accommodations.
That's the stuff that changes your actual life.
It is. And then there's the emotional component, which we just cannot overlook.
Yeah.
We talked about the small feeling of isolation. There's a phenomenon that's often called the mirror effect.
The mirror effect. I haven't heard that term.
Imagine growing up and almost never seeing anyone who looks like you. Turner syndrome, like many genetic conditions, can have a distinct phenotype. Statistically, there are physical traits that are more common. So you walk into a room, any room, and you are the outlier.
You're always the one.
You're always the one. Then, for the first time, you go to a national Turner syndrome conference. You walk into a hotel ballroom, and there are 200 other girls and women who look like your sisters.
Oh, that must be an incredibly powerful, validating experience.
It is transformative. For the first time, you see yourself reflected back at you. It recalibrates your entire sense of what normal is. For that one weekend, you are the norm. The world is built to your scale.
It takes the small out of the equation entirely, at least for a little while.
It completely removes it. It validates that your existence isn't a mistake or an error. It's just a variation of the human experience.
Yeah.
And it's a variation with its own culture, its own inside jokes, its own shared language.
I love that idea, that it's not just a support group for medical condition, it's a culture.
It really is. It's a tribe.
So we have traversed, wow, quite a landscape here today. We started with just 4 words. She's small but mighty.
Feels like a long time ago.
It does. And from there, we've unpacked the genetics of the X chromosome, the mechanics of height and heart health, the psychological hurdles of a delayed diagnosis, and the incredible crowdsourced power of community.
It's a full ecosystem, isn't it? You can't separate the biology from the biography. The small, which is the genetics, it dictates the nature of the challenge.
Right.
But the mighty, which is the diagnostics, the strategies, the support, that is what dictates the life that's lived.
And I think for me, the biggest takeaway for you, the listener, whether you're personally in the rare disease community or you're just an observer like me, is about redefining what we even mean by strength.
Yes. Strength isn't just about physical power or the absence of challenge.
No.
Strength is adaptability. Strength is learning to navigate a healthcare system that fundamentally was not designed for you. Strength is finding joy and purpose and meaning when your genetic blueprint threw you a massive curveball before you were even born.
And that leads me to the provocative thought I want to leave everyone with today. It's something that's been nagging at me throughout our conversation. Okay, we've spent a lot of time today praising the resilience of these individuals and their families. We call them mighty. But is that letting the rest of us off the hook a little too easily?
That's the uncomfortable question, isn't it? Are they mighty? Because they have to be. Because our systems are so rigid and unaccommodating.
Exactly. If small but mighty is the phrase that defines their experience, how does society's view of rare need to shift to better support that mightiness? So maybe it doesn't have to be such a fight.
What would that look like?
I don't know. But what if we made our schools truly neuro-inclusive by design, not by exception? What if we made advanced diagnostic tools faster, cheaper, and more accessible to everyone? What if we started viewing genetic difference not as a deficit, but as valuable data about human diversity?
Then perhaps they wouldn't have to spend so much of their energy, their mightiness, just fighting to exist on a level playing field.
Right. They could use that incredible mightiness for other things.
For art, for science, for discovery, for joy.
A fundamental shift from survival to flourishing. Maybe that should be the goal for all of us, not just for them.
I couldn't agree more. A perfect place to leave it.
Thank you so much for going on this deep dive with us. It's really been an eye-opener to look past a simple label and see the complex logic and the powerful life underneath.
It's always a pleasure to explore the nuance. Thank you.
Stay curious, stay mighty, and we will catch you on the next deep dive.